I work in the referral and assessment team. This is quite getting thrown in the deep end because I wasn't meant to be doing this. So kind of just bear with me if there's a little flaws anywhere. I've got my colleague Annette. She will be taking the second part of this presentation. And I've also got my colleague David, who's going to be assisting me with the slides. Okay. So part of what we're going to be going through today will be the facts and figures, harm reduction and reducing mortality, joint working and why it matters, our pathways, and also our care coordination model and the referral and our open access system. So the figures we got here, and facts and figures we've got here is BDAS. We've worked with about 1,200 people over the year. And since 2013, we've reported 29 deaths, which kind of averages to 7 to 8 deaths per year. That has been reported to the commissioning team. And we've made 4 reports to the coroners. And these reports are done by the service manager, whose name is supposed to be up there. Part of what's been explored through these reports has shown that the prevalence deaths with alcohol has been 1.8% in our client cohort, and for alcohol and for drugs it's been 0.94%. And nationally, the cohort mortality rate has doubled since in the general public. And it shows that the average age of death in our service users has been between 49 and 50. So majority of the service users has passed away have been between those ages. Majority of them I've worked with, I should say, not privileged to, but because I've been there since 2012. It's quite a difficult situation that we have to go through, but that's what happens when there's alcohol and drugs involved in long-term service use. And it says here the average life expectancy for Bromley is 84%. Some of the figures we've got here says nearly 50% ratio of men and women. So it's an average of 3 to 1 client. Part of the service, part of the, sorry, just gotta get this right. So part of our, I'm trying to explain, partner agencies that we work with is Oxley's, and we've got about 64% that is shown through our care management teams, that's the adult social services, and 57% through the mental health team. Okay. And it also states that it's not all the cause of deaths that's been identified as alcohol issues, even though a majority of our clients, as high as 27% have liver disease, 21% have heart failure, and also 21% have cancer. The overdose rate is 11%, and suicide rate. We've got 30% of our clients who have COPD, and 20% who have asthma. About 90% of the clients who access our service show improvement after 12 weeks, and we get this through our treatment outcome profile, which is called our TOPS. To the next slide. So the next slide is about preventing drug-related deaths. Sorry. And majority of these are, I think I've done it the other way around. Yeah, let's go through this. The pages are different. Sorry. Okay. Okay, we're looking at what's working and how we manage missed appointments. We've got some statistics that shows that over 25% of our service users in the last year missed their appointments, and this don't include cancellations. So learning from the deaf investigation shows that an indicator of increased risk in service users is when they miss a lot of appointments, averaging 2 missing appointments. So we look at how we can manage these by re-engagement processes and learning from a lot of the missed appointments, where we can combine service use, combine other partner agencies to try and get service users back into treatment. So when they miss like medical appointments, how important that is, especially for service users with health implications, alcohol-related illnesses and stuff like that. So we try and look at what works and how we put this into consideration and try and getting them back into treatment. So I'm not going to go through most of all this stuff on this slide because I find myself just reading it back to back, and I have to apologize because everyone's got some of this information that we can use in the future. So preventing drug-related deaths in overdose. Again, this is previous overdose greatly increases in the risk of dying from a later overdose. So a lot of these are clients who inject, clients who are poly drug use, which is alcohol and drugs, which obviously has a high risk on their liver and toxins. Clients in titration, which is the early stages of treatment in our substitute prescribing clients. And the ways we look at preventing these come through as things like get them on this opioid substitute prescription, using things like naltrexone. And the high-risk clients in these areas are a lot of our hospital discharges and prison releases. So this is a slide done done by Jonathan Williams with our facts, and this is like a titration slide, and our harm reduction processes that we use. We offer things like naloxone, opioid substitute prescribing, and needle exchange. The highest death in opioid clients are injectors. So these are things that works in reducing deaths of our service users. The clients in this cohort that are mostly at risk, as I explained, are hospital discharges, a lot of clients with mental health issues, clients who have gone through tier 4 treatment, which is like rehabilitation. So they've got quite a very low tolerance, and prison releases as well. So what we do to reduce this risk, again, is about following our policies, our procedures and protocols in engaging clients through missed appointments and trying to get them in as quick as possible. And that helps us with joint working, liaising with mental health teams, also liaising with homeless agencies, and trying to get them a robust care plan with other partner agencies. This is what we call our Datex, and it's also a learning tool where we report all our deaths and incidents. These deaths are done by any member of staff, and it gets handed over to the service manager. and we look at management plans in the future, how to avoid these things. And we've got what we call a gold, silver, and bronze system that we use. For example, if we've got a prison release, we will actually look at someone to nominate as gold and someone to nominate as bronze and silver. That process has helped us manage a lot of risk in the past, where with that nomination, people have a responsibility of what to do, where and when, and who, and the responsibilities each, either gold, silver, or bronze, has to manage. But the bronze is who we have, the gold is who we have to feed back to, and he's going to be the number one contact to liaise with other partner agencies. Next one. Interagency working, which is very important, and I suppose is part of what this conference is about. How we work together to safeguard adults. In our case, we work with adults, and we've got young people service. My role also covers safeguarding meetings, reviews, three-way meetings, professional meetings, community care assessments, home visits. So we try our best to work together with a lot of partner agencies, especially mental health services and social services. We also do working with the DEEP team, which involves probation and the police. Okay. Go to the next one. The treatment and care coordination, which is one of my main roles as a care coordinator, says that treatment needs to focus on the long haul. Services should tolerate and continue to work with service users who have poor attendance record and who do not comply to their medication. It is important that we spend this time is spent engaging service users with dual diagnosis before treatment plans are made, for a variety of reasons. We kind of face a lot of struggles when it comes to mental health clients, especially clients who kind of drop in and out of treatment with severe mental health issues. We're still working. We're doing a lot of good work. At the same time, we struggle with a lot of these cohort of clients in terms of re-engagement, in terms of signposting, getting their mental health assessment, because they use drugs and alcohol. So a lot of the focus in here around the treatment should be the engagement, enhancing motivation for change, active treatment, relapse prevention, access to full range of substance use services and mental health services, as appropriate availability of range of pharmacological, psychological, and social interventions. We do a lot of these in our services regarding prescription clients, and we try not to just give them the medication. We try and encourage clients to do a lot of psychosocial intervention. For opiate clients, their average lifetime spent in services is about 3 to 3.5 years. So you can imagine what we go through trying to keep these clients in treatment to try and get successful outcome. We do get that in the long run, but by working jointly with other services and putting a robust care plan together, I'm sure it would improve the service users' time in treatment and after. So joint care, recovery planning, and multi-agencies responses is what we're aiming to achieve when working with clients in opiate dependency. I think I'm going to hand over to my colleague. And thank you very much.
Hi, my name's Annette Devine, and I'm the alcohol recovery worker at BSAB. And my role primarily is to work with the harm reduction clients who wish to either control their drinking or bring it down to an abstinent level. But I also work with dependent drinkers who need detoxification within the community, or if necessary due to physical health needs, perhaps as an in-house detox. So just a few facts to start with. Almost half of violent assaults involve alcohol. It also features very heavily in domestic violence and marital breakdown. And can I just, on that, it's both sides. It's predominantly, we always judge that it was male, but there are increasingly a lot of females who are becoming perpetrators. 20%, excuse me, 27% of serious case reviews mention alcohol misuse, and the physical, psychological and behavioural problems for children of parents with alcohol problems. So we're seeing more and more now that learnt behaviour is coming to the fore. And then 13% of all road fatalities involve alcohol. Okay, so just to give you a general idea, this goes up to 2015, and in that year, for the whole of the country, £3.72 billion was spent on NHS hospital admissions and deaths relating to alcohol. And for this, we've just given you a breakdown of the numbers involved. So this is going from 2008 up to 2015, and it is steadily increasing. But the more worrying thing is the females are increasing at a more rapid rate than the males. So a lot of females are getting themselves into very risky situations, which are ending up with them in hospital. So how do we assess whether or not somebody has an issue with alcohol? So I'm not sure how many of you are aware, the government have a low risk guideline now instead of a safe risk, and that's 14 units a week. And in your handout, you have been given some information about, excuse me, some information about units, but just to clarify a few things of what a unit actually means. So when I was younger, a glass of wine was a little glass like that. And when anyone bought you wine glasses, you tended to have a glass of wine. 125 mils, I think it is. Nowadays, if you go into the more luxurious shops, they're selling wine glasses that are this big. So a lot of problems stem from people thinking I'm only having one glass of wine without actually taking into account how many units they're consuming. So if we take half a pint of regular beer, lager or cider, that's 1 unit. If we take one single measure of spirits, that's 1 unit. A lot of problems stem from people that drink at home don't tend to pour themselves a pub measure, for example, of vodka, which is probably about that much. And then each of these is more than 1 unit. So a regular beer, lager or cider has 2 units. The danger we have now is alcohol is extremely cheap. Very strong alcohol is extremely cheap. So it's very easy to buy a can that has 4 units in it for 99p. So it's a big danger we have. And the average bottle of wine has 9 units. So if you take into account, when the government says low risk, it means 14 units over a period of 1 week with 2 to 3 days off. Doesn't actually take into account having 1 bottle of wine on a Saturday night. That's actually classed as binge drinking, which is extremely dangerous. And I had it quoted to me that when you do binge drink, and we're talking now if you're going over the 1 bottle of wine, it's like opening up your arms and taking body punches and not putting up any defence. So that's just a bit of information about units. So how do we assess? We start with this Frames toolkit. It's available online. The first 3 questions we ask is to determine whether somebody does have an issue with alcohol. And bearing in mind, for some people, they don't have to drink a great deal for it to impact heavily on their lives. So some people might be able to drink 1 bottle of wine a night quite happily, get up, go to work, kids are fine, job's fine, family life's fine, no financial worries. Someone else might drink 1 bottle of wine a night and their whole life could be chaos. I've actually worked with people that drink in the low risk unit per week and have ended up losing everything because when they do drink, their whole life goes out of control. So the first 3 questions we ask: how often do you have a drink containing alcohol? Then, how many standard alcoholic drinks do you have on a normal day when you have a drink? And how often do you have 6 or more drinks in one session? And then within your packs that I've given you, there is the more extended frames toolkit that we use that goes into greater detail, particularly, have you ever been injured? Do you wake up in the morning feeling unwell? How often do these sorts of things happen to you? Sorry, next one. And then depending on the score that they get on their frames audit, depends on the sort of interventions that we offer. Now, we do realise that some people are referred to us in many different ways. So we could have GP referrals, we could have probation referrals, we could have mental health referrals, we could have social services referrals. And then we can have people that it's been recommended by friends or family, or people that actually just want to come in for themselves. They've recognised that they feel that alcohol is a problem in their life. So it's up to us to then offer different interventions depending on what their score is. So as it states, 0 to 7, they don't really need any treatment support from us. 8 to 15, we can offer brief, structured sessions, giving more information about what the likely harm could come to them with continued long-term drinking. If they score between 16 and 19, this is when it's becoming more of a hazardous level. So this is when we also have to look at doing a severe alcohol dependency questionnaire to see whether or not they are physically dependent. And the pathways that we have at BDAS are broken down into whether they're physically dependent or whether they're not. Now, I'm not sure if you're aware that if you are physically dependent on alcohol, it is unsafe to just tell someone to stop drinking there and then. Alcohol is the only drug that you can die from. Okay? You can't die from overdosing on very much else, but alcohol, withdrawal. Alcohol is the only drug you can die from on withdrawal. Okay, so you cannot die from heroin withdrawal, but alcohol withdrawal you can. And it's not just the fitting in the seizures, it could be the complications by falling over, smashing heads, having accidents, walking out into traffic, committing suicide. So, if you score between 16 and 19, we offer the harm reduction pathway. It's a 16-week programme and it offers psychosocial interventions, coping strategies on how you can cut down safely, either to the government's low risk or to abstinence, depending on the considered choice that the client has made. If they score above 20, they then deem to be dependent on alcohol, and they follow a different pathway with health sessions, doctor's appointment, and they are put forward, if they would like it, to do a community detox. So we do a detox within the community every 6 weeks for clients that are deemed to be dependent. This involves the first week, they are prescribed medication to manage their withdrawals. They also have psychosocial interventions for the whole of the 2-week process. I can't read that bit, and I'm lost. So, after they've done the detox, they can then access our aftercare programme, which we also provide, which can last for 16 weeks, and they can then access all the opportunities that are available, that I will talk about in a little while, that are offered by our peer support community. I've done that one. So as I mentioned, we have different pathways. So somebody will come into our service and they will be assessed, and as I explained, depending on whether they're deemed to be dependent on alcohol or not will determine the pathway they take. So the first pathway on the left is the alcohol harm reduction. They will have a series of 3 interventions. After that, they may decide that they've learnt enough, they don't wish to continue with support. And if they do decide they want to continue with support, they are signposted to the harm reduction groups. These initially were 12 sessions. We've now raised it to 16 because we also incorporate a lot of what Bromley Healthcare are promoting. So we do different awareness weeks. We've done domestic violence, we've done hepatitis, we've done mental health. So we incorporate what's also going on in the borough into our sessions. We also offer groups for people who are taking stimulant drugs along with alcohol. They have a separate pathway. And we also have a pathway strictly just for the stimulant drugs. So that's your cannabis, your legal highs, your cocaine. On the right-hand side, if they're deemed to be dependent, they then have a comprehensive assessment straight away. They will have a healthcare assessment with one of our nurses, and they will have a medical assessment with our consultant psychiatrist. They are then signposted into health and wellbeing pods. To get them ready for the detox, they do a series of 6 sessions, all around focusing on the cycle of change and how to break habits, look into the future, what their life would look like without alcohol. As I said, they then do the 2-week detox programme. They then go on to our aftercare service down at Norton House in Bromley South, and they can access what we have set up as called a Design for Life, which is a basic support network offering all different activities from their own little band they have going that's quite successful. They do flower arranging, they do a creative group, they have coffee mornings, they do a men's group, they do women's group, they do everything to do with emotions. So they're looked after, they're not just detox and then passed on. So this is the range of services. So a lot of people, they know a bit about what we do, but they don't really know how we do it and all the opportunities that are out there for our clients. So we have what we call a Foundation of Recovery programme. So our new logo, is Change, Grow, Live, and that's the title of the 3 sections of the recovery programme we have. So we have the changing, the growing, and then the living. We have care coordination model, where they're followed through from their assessment right the way through for the end of treatment, with regular reviews every 8 weeks to ascertain how they're doing. We have health and wellbeing clinics run by nurses. We offer a counselling service, not just for our abstinent clients. This can be accessed by our harm reduction clients who are looking for support, that little bit of extra work around why they turn to drink in the first place, why they use it to cope, what they can be using instead. We do an 8-week, the pod work that we do. So rather than do one-to-ones, we aim to work with groups of 5 people. The reason it's called a pod is after the P, so it's like-minded people going through the same sort of thing at the same sort of time. We aim for 5 in a pod. Sometimes it's a lot more, but it has very, very good success rates compared to one-on-one working. We offer an 8-week stimulant treatment programme. We offer needle exchange, and you don't have to be a registered client with us to access that. We offer hepatitis C testing and Hep B vaccination. And when it says hepatitis C, we also test for HIV. We offer ear acupuncture. So a lot of our workers, myself included, of trained NADA practitioners, specifically working on 5 key areas in the ear that have been identified to help with craving, stress, anxiety. We work with prisons and the DIP services. We do an opiate substitute prescribing and detoxification program. We do the community alcohol detox. We do family and carer support services. This is a very important part of our work, where we get a support network of people that are suffering themselves with a partner or loved one going through addiction. We do referrals within the community for residential and detoxification assessment. Not all of our clients are suitable to be detoxed within the community. It could be they have high-risk physical needs or polydrug use. From our buildings, we run a lot of mutual aid. We've recognised that although the quality of work that we do is outstanding, we do work within a framework of 2 late nights and then the regular office hours. So our mutual aid forms a big part of any of our clients' recovery. And they include Narcotics Anonymous, Alcoholics Anonymous, Cocaine Anonymous, Co-Anon, LifeRing, and Smart Recovery, and they all run from our premises. And then the Design for Life, this is our peer-led activities. This was set up so that when clients have achieved their abstinence, they're able to maintain a network of supportive people and go out and have fun, basically. And then we also offer peer mentor and volunteering opportunities. A lot of our peer mentors were detoxed by us or by other services. A lot of our volunteers follow through the pathway, and equally some of our staff. Oh, it goes on. Okay. So where we work from, so for any of you that don't know, we work from a big old Victorian building opposite the Travel Lodge in Bromley. Okay, so it's on London Road. We also have another service which we call our aftercare service, and that's down at the bottom by Bromley South, and that's known as Norton House. That's where our counselling takes place. That's where a lot of our abstinence-based groups take place. And it's a safe building for people to go. It's a safe building in that people know that they're not going to be subjected to people who may still be using drugs and alcohol. We also do satellite clinics, so we work from Holy Trinity Church in Penge with Nick the Vic, well known in the community for what he does. And we also work from Orpington Village Halls. So this offers our clients the opportunity. It's a big old borough, is Bromley, and people living over the Penge side might not find it so easy to travel to Bromley every day. Equally, the ones that live over in the Crays might find it really hard to get into Bromley some days. So we offer it in Orpington and Penge to cater for the size of the borough. We also work from Princess Royal University Hospital and Green Parks. So one of our workers goes on a Friday, picks up all the referrals, sees patients on the wards, does some psychosocial interventions, but also encourages them to come into our service when they finish their treatment. We work from HMP Highdown and Bromley Police Station. So we have a worker from 7 to 11, Monday to Friday, picking up the people that have been arrested overnight with drug and alcohol-related crime. We also work closely with a number of services who provide clinics within our services, such as probation, Job Centre Plus and dual diagnosis. We've also just started working with the Bromley Women's Aid. We have an IDFA comes in on a Tuesday to work with our clients who are experiencing domestic abuse. Our open access service undertakes the initial assessment of a person's needs. This can be done by a self-referral or from our partner agencies, and in your pack you do actually have a assessment referral form. And we operate this assessment service Monday and Friday 10 till 4, Tuesdays and Thursdays 1:30 till 8, and Wednesdays 1:30 till 4. So, a collaborative model. So this sums up basically our care coordination from the referral, the recovery plan, the assessment, the consistent reviews, our safeguarding, and our community care assessments. We have the health and wellbeing pods, which looks at titration, BBV test and vaccination, harm reduction, overdose awareness, and alcohol detox. And in my considered opinion, equally as important, if not more, the psychosocial interventions, I can't read the yellow, so, which is the foundations of change, growth and life, substance-specific pods and key working. So some services, they do a more generic way of working, whereby you could be working with a cohort of clients who are opiate users, stimulant users and alcohol users. We've identified that they have, although addiction is addiction, they still have different needs. So we separate them so they're working with the same substance. And then for those of you that know Jonathan, if any of you have ever met Jonathan, our service manager, he loves a map. So this is our jigsaw of what we do all day, every day. So we have our health and wellbeing opiates with the foundation of change, foundations of growth, foundations of life. We have our alcohol with the pre-detox for the dependent drinkers. We have the harm reduction for the non-dependent drinkers. And we have the foundations of life for the abstinent and those who wish to control their drinking. Because we also recognise that some people, they just want to cut down their drinking. They don't necessarily want to stop. It may well be they just want to be able to drink on a social occasion. Then we have the non-opiate, and again, the foundations of change, growth and life. Our satellite work, Cotmandine's still on there, but we don't actually use that anymore. We have our ambulatory opiate detox, the family and carers group, the ambulatory alcohol detox, care coordination, over-the-counter and prescribed medication pods. Particularly prevalent at the moment is a lot of codeine users are coming through the service. And some of them have been prescribed for years and years. We have service user involvement, so our own collection of clients have their council. They meet on a weekly basis. They decide what improvements they would like within the service. They like to feed back to us what improvements they would have. They put on all sorts of different events, barbecues throughout the year, which quite a few agencies are invited to. And they also came within the top 10 at the Recovery Film Festival for 2017. So they made a 3-minute film about what recovery meant to them. And they got top 10. So that was a very proud achievement. Our Design for Life, as I've said, is set up by the service users, for the service users to support them in their recovery further along after they've completed the treatment with us. And then the community justice involvement. So this is all the different ways we work. We have ATRs, which is the alcohol treatment requirement, and we have the DRRs, which is the drug requirement. So basically, probation refer clients to us as part of their sentencing. They have to attend our services. And finally, this is what our referral film looks like. And one thing I would ask, when you make the referral, if you make the referral to us, it's really important that we are made aware that you have the client's consent to do so. Because not so much now, but historically, referrals have been made and the client hasn't actually wanted to come to us. And it causes a lot of paperwork backwards and forwards. And it also can be quite distressing for the client who's getting phone calls from us saying, when are you coming in? Here's your appointment, and then getting letters. So if we can just have on it that they've actually consented to the referral, that would be a great help.
Good afternoon, my name is David Dunkley and I'm the team leader for Bromley Changes. Bromley Changes is a young people's drug and alcohol support service. We are part of the same charity, CGL, along with the adult service, but we will specifically work with young people from the age of 10 to 18, and we're commissioned by the local authority. So first and foremost, we are an outreach team. So what that means is we won't arrange, unlike the adult service where they'll arrange appointments to see clients at their premises, we don't do that. We're totally opposite. As an outreach team, we will go out within the community to engage with young people to help keep them engaged in treatment. That could mean attending schools, colleges, doing home visits, going to youth centres. Sometimes it's just a case of having a catch-up. So we might be, taken for a cup of coffee, Starbucks. We also may need to go to the youth offending service where some young people are on court orders, where it's part of their court order where they need to engage with us. Just at the bottom, we've put here an holistic approach. And what I mean by that is when we first meet with a young person and we do a full comprehensive assessment, and we'll look at different aspects of what's going on for that young person in terms of what other support they may need. And we'll try and tackle those areas first before concentrating on their substance misuse. Now, as in you and I would both agree, what we deem as a priority for young people in terms of what they should be working on and what they deem as a priority is two different things. So by looking collaboratively with the young person in terms of all the other areas first, be it if they're having problems in school or problems at home, etc., or maybe they're homeless, try and supporting those areas first, and then their substance misuse works much better. So what we offer. First off, we're a confidential service, and we're also a voluntary service. So to lead on from what Annette was talking about earlier, it's really important when a professional or even a parent is making a referral to us that you've had that discussion with that young person first. There's no point making that referral and then expecting them to want to engage with us, because that's not how it works. If you're having a conversation because you've got concerns with that young person around their substance misuse and they're not too sure and again, still give us a call, because then sometimes it's a case of us having a three-way meeting that would be like us, you, and them, and giving us a chance to speak to them about the service and how we can support them. Because sometimes it's just a case of them having a meeting with us and sort of sussing us out before they agree to work with us or not. Now, when we work with young people, we work with them in blocks of 6 sessions. So we do it that way so they don't feel like they've signed up like to a long-term contract, and that seems to work much better with the young person. So we'll work with them, we'll do the assessment, we'll look at their substance misuse along with short-term, long-term effects and their associated risk. It could be they just want more information around it, or maybe they actually do want to reduce or to totally abstain from the substance. We'll work along those sides. At the 6th session, we'll have a review, and that could be either just with the recovery worker and them, or the person who first referred them, parents, etc. It's totally up to the young person. And we'll have a look at the work we've done with them, and they will get to decide if they want to see us for another 6 sessions. Advice and support is what we give out first and foremost. And one of the ways that we do that is, at the moment, we're currently in the process of setting up a satellite in all of the secondary schools, including the pupil referral units. So all in all, we're talking around 23, 24 schools. And the satellite is a chance where they can come and speak to us about any concerns they have, or maybe it's just to find out a bit more information around drugs and alcohol. And as a result of having conversations with us, if they want to self-refer to us, then we can arrange that with them. So we don't have to receive a referral purely by, like, say, a parent or professional. They can also self-refer as well. So we are an experienced team of recovery workers in substance misuse. One of the interventions we do is either on a one-to-one basis or on a group intervention basis. So we have a group program where if a school has identified a small group of individuals with substance misuse concerns, then they can take part in a group program, which can run over a course of 5 days or 5 weeks. So that's where they get to meet with us, where we get to see them anything between an hour to an hour and a half. Again, looking at their substances, giving them harm reduction advice as well. And at the end of the group program, which they each will receive a certificate, they will also have the option to then do further one-to-one support with us at the end of that program. So, as I said, doesn't have to be a professional, can be the young person themselves. I've tried to break down as many barriers as possible in order for someone to refer themselves to the service. Now, initially, because I've been in post now just over a year and a half, initially when someone needed to make a referral to the service, they'd have to go through the Bromley Wellbeing Service. To me, that was a barrier in terms of getting a young person engaged with us, because with young people, you need to get in there as soon as possible. So with the help of our commissioners and the commissioners of the Bromley Wellbeing Service, was be able to take that barrier down. So now we can accept referrals and do our own assessments rather than going through another provider. The referral form is very similar to the one that you saw that Annette showed. 1-page document, well, actually it's 2 pages, but the first page, as you saw, young person's details, their chosen substance misuse, summary box of what your concerns are, because sometimes it's not necessarily that they're misusing, but maybe they're on the cusp of it because of their friendship circles. And then obviously your referral details. The second page is a risk assessment, but you don't need to do that because when we first meet with them and they agree to work with us, we will do that in our assessment anyway. You can also contact us by phone, email, social media, fax, etc. We will receive a referral even face-to-face. So like I said, we try and break down as many barriers as it is in order for that young person to get in treatment. When we first receive a referral, we aim to contact the referrer, and that could be either the person that's made the referral or the young person themselves within 5 working days. Usually then we're able to arrange an appointment within the first, sometimes second week of when we receive the first referral. So we work in partnership with a lot of services, and that could be along with the adult service, offending service, CAMS, schools, and also various other agencies. I attend the safeguarding psychosocial meeting at the Princess Royal Hospital. So that takes place every Friday, once a week. And basically what it is a group of professionals from myself, social services, nurses, consultants, etc. will sit around a table and we will discuss all the young people that submitted that week. And any that has substance misuse have been identified, then we will pick them up. We've also got a referral pathway in place. So if a young person is admitted over the weekend, they'll make an automatic referral to us. One of the things that you will hear about agency work is having strong partnership. And I can't emphasize how important that is. Because I've worked in numerous boroughs now, and I think this is my 7th borough. And you always hear, oh, it's good to work in partnership. But there's partnership working, and then there's partnership working. And as far as I'm concerned, partnership working is working extensively with each other, keeping that dialogue open, attending team meetings, telling us, what's new updates about your service and vice versa. We also provide training for professionals as well. So we can do a basic drug and alcohol awareness training, help you look at the telltale signs and how to have those discussions with that young person about your concerns around their substance misuse. One of the things that I put in place in terms of to strengthen the partnership work between the young people service and the adult service is earlier in this year I put in a transitions protocol. So where our cutoff point is 18, in my experience, the 19 to 21-year-olds, they're still classed as young people, even though that in the eyes of the law, they're adults. And what I've put in place is where we will work with that particular age group as well, albeit only for like 6 to 8 weeks, in the aim of transitioning them over to adult services. And even then, once we refer them over to adult services, we will still keep them open for a period of 4 to 6 weeks. So basically, we meet with them, we work with them, do the assessments. We will then meet with the recovery worker from the adult service along with them. So it's a three-way meeting, so we will escort them there. Because obviously sometimes we're young people, it can be a bit daunting and they feel a bit anxious where they're going to an adult service. If for whatever reason, once they have transitioned over, that they do drop out, then we will try and help pick them up again to try and resolve whatever the issues are. So here, as we can see, we do outreach, satellites, drug and alcohol awareness workshops in schools and youth centres. So up until March this year, we was working in partnership with the Bromley Healthcare Sexual Health Team. So we was in the part of the Your Choice, Your Voice programme, where that was doing the SRE work in secondary schools with the years 9 and 10. And that ran for, I think, a year and a half, and it was quite successful from the feedback that we're hearing from both the students and also from the teachers at the schools. So we also take part in community awareness stalls, events. Like I said, we attend lots of team meetings, doing presentations, giving out leaflets, etc. And also, as I said, we do training as well. And that's just some of the lists of some of the key partnerships. Some of them I've already mentioned as well. And that's it for my part. So thank you very much for listening to the whole presentation. And we will now open the floor to any questions.